Okay, well, greetings everyone, and thank you, Dr. Ayler, for that kind introduction. So, those of you who have rounded with me have spent a fair amount. We spent a fair amount of time talking about this exact subject. So, in fact, this is some of the data to back up some of the statements that I've made during rounds before. So, I did initially this presentation to a group of stem cell transplanters, and that's why it states it's extended spectrum azoles in BMT, a practical guide. But really, I think 95% plus of this lecture really applies to anywhere infectious disease. And there's just a few oddball chemotherapy-related slides, which maybe it wouldn't be bad to have in the back of your mind in case this were to come up on a unusual consult. So basically, I'm going to start with a very brief why should we care about this topic around the table here, and then I'm going to compare and contrast the newest of the extended spectrum azole antifungals, and specifically focusing on Voriconazole and Posaconazole. We'll talk about the antifungal spectrum, their clinical indications, the adverse reactions that we most commonly encounter are most significant, some pharmacokinetics and dosing, but only where it's real life important in patient care. I'm going to try to avoid anything that's esoteric or doesn't really make a difference on a day-to-day basis. We'll talk about some of the drug interactions, and very briefly, I have a slide on cost. Okay, as I think we know, some of the more immune-compromised patients that we see, your stem cell transplant patients or your solid organ transplant patients, the majority of these infections are caused by Candida species and Aspergillus species. 71% in this particular series, but still 42% were caused by other fungi. So this was a kind of a garbage bag here of zygomycoses and cetosporum and histoplasmosis and fusarium. So it shows us that yes, we have to think about Candida and Aspergillus, but we can't forget about the others. So broad spectrum agents are very helpful. And of course, when these highly immunocompromised patients do develop a candidiasis or an aspergillosis, obviously we know that there are very significant negative impacts associated with that. In this particular series of stem cell transplant patients, there was a 24% attributable mortality to invasive candidiasis. Excuse me. Aspergillosis, even worse. Now these are gross mortality data, not attributable mortality data, so they're slightly exaggerated. But nonetheless, you can see that among stem cell transplant patients who develop an aspergillus infection, invasive aspergillus, more than half of these patients will die, and very often 3/4 of these patients will die. Of course, they're often quite sick by that time anyway. So these are the extended spectrum azoles that I'm going to kind of focus on. And just wanted to kind of point out, it's a little hard to see the itraconazole, but you see fluconazole and voriconazole have a very similar chemical structure. In fact, voriconazole is manufactured from fluconazole by one single synthetic change. You'll notice itraconazole and posaconazole both have similar, much larger structures, and there are some tie-ins here when we start talking about the pharmacokinetics and drug interaction issues between these agents. There are some similarities that we want to note between fluconazole and voriconazole versus itraconazole and posaconazole. So in terms of the availability of these drugs, voriconazole or VFend from Pfizer is available in 50 and 100 and 200 milligram tablets, also available as a powder for oral suspension, and an IV formulation. Also important to note that the IV formulation contains a sulfa-butyl ether beta-cyclodextrin solubilizing agent. This actually does become somewhat important later on in our discussion, particularly in patients with renal insufficiency. Posaconazole or Noxafil from Schering is only, unfortunately, at this time available as an oral liquid formulation. Okay, I think we all are familiar, at least in general, with the mechanism of action of the azole antifungals. We are going to inhibit the cytochrome P450 dependent demethylation of 14 alpha sterols. So we wind up with a increase in in an accumulation of these methylated sterols, and we wind up with a deficiency of ergosterol, which is a critical component of the fungal cell membrane. So a combination of these actions results in profound damage to the cell membrane of the fungi. And interestingly enough, tends to result in a more fungistatic effect on Candida, whereas a more fungicidal activity versus Aspergillus. Obviously not talking about only for those azoles that are active against Aspergillus. So in terms of spectrum of activity, I just stole this from the Sanford guide because it was a nice little breakdown. Just want to take an opportunity to point out a few differences among the different species here. So, of course, Candida albicans is sensitive to everything, usually, although there certainly have been case reports of resistant Candida albicans, but generally speaking. Candida glabrata is considered plus minus for fluconazole, and this is because the majority of Candida glabrata are actually resistant to fluconazole at standard doses, but have a dose-dependent susceptibility where if you push your fluconazole doses up to 16 milligrams per kilogram per day, 800 milligrams a day, you can still treat the vast majority of Candida glabrata. And this is because it's an efflux-mediated resistance pattern. C. tropicalis and C. parapsilosis are usually very fluconazole sensitive. Candida krusei is intrinsically resistant to fluconazole due to the alterations in its cytochrome P450. And Candida Gellermunde and Cryptococcus are also pretty sensitive to fluconazole. Now, when we go to the extended spectrum azoles, you'll see that, of course, C. albicans, no problem there. For Candida glabrata, actually, the majority of these will be susceptible to voriconazole and posaconazole, but interestingly enough, they tend to do even better against Candida krusei because they actually fit well into that altered cytochrome P450 structure. So a lot of times we say non-C. albicans, it must be fluconazole resistant. What we really could use would be a non-C. krusei report. And I just have here the data with amphotericin B and the echinocandins, and of course, Candida parapsilosis is usually quite treatable with the echinocandins, but it does tend to have the highest MICs amongst the Candida species. So if we have a failure or breakthrough, it tends to be parapsilosis. All right, moving on. So for our molds, we know fluconazole is completely ineffective against the molds. Voriconazole and posaconazole are in vitro. They're the best agents we have against Aspergillus, including Aspergillus terreus, which is amphotericin B resistant. Very important point there. They are superior to what we have elsewise against Fusarium, although there are those who argue for a combination of lipid formulation amphotericin B with one of these drugs. Also, Cedosporium apospermum. Nothing's very good against the Cedosporium prolificans. And the big difference between voriconazole and posaconazole, of course, is that posaconazole is highly active against the zygomycoses, Mucor, Absidia, Rhizopus, for example. Whereas voriconazole has a big hole there. And in terms of some of our more uncommon agents, such as Alternaria, Bipolaris, Curvularia, Exfolia, voriconazole and posaconazole tend to be very active there, more so than our other choices. The dimorphic fungi, they're also quite active, although itraconazole here is mentioned as a first line for dimorphic fungi and active clinically. I will give you some of my biases against itraconazole, but I have to give the devil its due. This is where the vast majority of the data is with the dimorphic fungi. And when you go by clinically evidence-based research, you're definitely going to go with the itraconazole. It's far better studied. Okay, in terms of clinical indications, voriconazole is FDA approved for the treatment first line of invasive aspergillosis. It's the only agent that has that other than conventional amphotericin B. Also for the treatment of candidemia in non-neutropenics and related disseminated candidiasis. They simply didn't include neutropenics in the study. It's not that we suspect that it would fail, but it's just understudied to get the FDA indication. Esophageal candidiasis, and they say salvage Cedosporium and Fusarium infections, but frankly, it is this drug is being used first line in these difficult to treat infections. Also, Voriconazole is approved for persistent neutropenic fever, and we have some data regarding antifungal prophylaxis for allogeneic bone marrow transplant recipients. The argument being whether it's of value frontline or whether it's more useful in the highest risk patients, those who have graft-versus-host disease and actually require high-dose corticosteroids, placing them at increased risk for mold infections. Posaconazole or Noxafil is approved for the prophylaxis of invasive Aspergillosis in Canada in patients who are severely immunocompromised, and nice language they managed to get in here, such as hematopoietic stem cell transplant patients with GVHD or those with hematological malignancies with prolonged neutropenia from chemotherapy. So those were the two groups that they really studied, and the FDA actually gave them a little wiggle room in their indication. So other patients who might be at comparable risk, you might get by an insurance company with, for example. Okay. Also, Noxafil has been used for the treatment of oral pharyngeal candidiasis, either frontline, which I don't know why you would ever do, or that which is refractory to fluconazole. Posaconazole has also been studied in terms of salvage therapy for patients with aspergillosis or zygomycosis. And due to lack of time, I won't go through these studies in detail, but if there are questions later, I have some cheat slides there at the end that I can hit. The zygomycosis data is the most impressive, whereas the aspergillosis data, I just had to mention that voriconazole wasn't really available when they did that study. Okay, some of the toxicities for voriconazole. The one that kept this drug off the market for quite some time was visual disturbances. And if you really ask your patients to really think about it, maybe about a third of them will report some kind of visual disturbance, depending how aggressively you dose your voriconazole, by the way, and we'll get into that. But at like 200 milligrams twice a day dosing, they may have some alterations in their visual perception, blurred vision, color vision changes, and or photophobia. Package insert says these patients should not drive at night or if they notice any change in their vision. And this is usually very mild. In fact, this statement, and patient is tolerating it, is a bit of a CYA by the manufacturer because they don't want to deal with any unnecessary legal cases. But most of these patients tolerate it quite well. If they're going to have these kinds of reactions, they tend to be early in therapy, particularly when they're getting intravenous voriconazole as compared to oral voriconazole, and particularly if the nurse gives the infusion a little too quickly. We had a little problem with that at first, and we had a number of these occur. So if you want to generate this side effect, that's how you do it. The site of action of this toxicity appears to be the retina, and effects normalize within 14 days after discontinuation of the drug. Now, a separate issue, one that we need to be very aware of, in the invasive aspergillosis trial, they noticed hallucinations and confusion distinct from the visual disturbances in 13% versus 5% for the comparator group. So there's no question that if you have a patient who's on voriconazole who develops new onset hallucinations, you definitely have to be thinking of voriconazole as fairly high up your differential. We'll talk more about the relationship between hallucinations, encephalopathy, and serum levels of voriconazole later. Dermatological side effects, about 6% of patients, mostly mild to moderate, but there have been cases of Stevens-Johnson's, TEN, erythema multiforme. A separate issue is that patients with prolonged therapy may experience photosensitivity, and all patients who are on this drug should avoid strong direct sunlight, use good quality sunscreen, UVA, UVB protection, at bare minimum SPF of 15, ideally 30 or more. And anytime a rash develops on voriconazole, this needs to be very closely monitored and consider discontinuation depending on the severity. Hepatotoxicity, of course, can occur with any of the azoles. Voriconazole certainly can cause clinical hepatitis. More severe cases like cholestasis and fulminant liver failure, including fatalities, are fortunately much rarer. But these patients, we certainly want to monitor the liver function tests before and after therapy with voriconazole. Also, cardiac, any azole can potentially cause QTc prolongation, especially if there are other risk factors such as electrolyte abnormalities, something to be aware of. And there have been uncommon reports of anaphylactoid reactions during voriconazole infusions. Now, I still haven't seen this, but it's worthwhile knowing that it's out there. Clearly, it's far less common with Vori infusions than with either conventional or liposomal amphotericin B infusions, but nonetheless, it is reported. In terms of Posacanazole's toxicity profile, when you look at the comparative toxicity data versus fluconazole, it's you can rarely tease out a substantial difference here. So you tend to see quite similar side effect profiles, generally quite well tolerated. Taste disturbances, nausea, dyspepsia tend to be among the more common that you encounter. Certainly, you can see LFT abnormalities with both drugs. Okay. And this is just some data on some of the more severe cases, and you'll see that, where it's something we need to monitor with posaconazole, it looks fairly comparable to fluconazole in most of these studies. This is a little data from Moffitt in terms of serious adverse effects requiring discontinuation. And we had 129 patients receiving voriconazole prophylaxis versus 38 patients with posaconazole in our acute leukemics. And you'll see, these kinds of adverse reactions I talked about. We had 4 hallucinations in this group, 2 LFT elevations, 1 rash, some QT prolongation. I think now I know I see more hallucinations as we push the doses of voriconazole higher and higher. Posaconazole, rash, LFT abnormalities, vomiting. So let's talk about some of the PK. And, that's the price you pay for having a pharmacist give a lecture. But these are important PK data. So voriconazole, first of all, is very well absorbed, okay, at 96% bioavailability. It doesn't get much better than that. Of note, if you take it with a fatty meal, you drop your Cmax by about 34% and your area under the curve by about 1/4. So therefore, it's recommended, don't eat for an hour before and after each dose of oral voriconazole. It's important to note that absorption of voriconazole is not affected by pH. So antacids, H2 blockers, and proton pump inhibitors don't seem to affect the absorption of voriconazole. Posaconazole, on the other hand, is a very different story, more like itraconazole. Okay, when you give posaconazole in a fasting state, you're likely to fail to achieve clinically relevant concentrations of the drug. So you're setting the patient up for failure. The best situation is the McDonald's Happy Meal here, which is a very high fat meal, 48.5 grams of fat. You can only do this in healthy volunteers. I think they timed this concurrently with a Super Size Me movie that came out recently. Like a Whopper. Yeah, but so you get a 4-fold increase versus fasting with that. But if you look at a non-fat meal, you still get an AUC 2.6-fold higher than fasting and Cmax 3-fold higher, and that's clinically meaningful. So if we can get patients to take it even on a non-fat meal or comparably with a nutritional supplement, so this is like 1 can of Boost Plus or Ensure Plus, you can get a comparable effect as to what you get with a non-fat meal. Interestingly, I did see some data saying that there actually is kind of a linear relationship here, depending on, this is with 1 whole can, so a little less, depending on the volume that you actually get the patient to take. I like to tell them to take it with ice cream. Okay, it's one time where ice cream might actually save your life. Okay, posaconazole. This is a slightly misleading slide from the manufacturer, but what they're saying is when they looked at twice daily dosing, 400 milligrams twice a day was the maximum exposure of posaconazole. What they would have been nice if they had on this slide is, here's 800 milligrams twice a day. It's saturable absorption. So once you're going to peak out your benefit, And actually giving the drug more frequently is going to be help you improve your absorption. But twice daily we use primarily for purposes of patient compliance issues. Now, posaconazole, like itraconazole, is dependent on, at least partially dependent on acid for absorption, gastric pH. So don't drop this stuff down a J-tube, okay? This is single dose data at times of what the Cmax and AUC that you obtain with just the drug by itself, the drug with ginger ale, doubles basically here. You see it drop a little bit with a proton pump inhibitor, and you can make up a little bit of that, but not too much with ginger ale. Ginger ale is somewhat acidic, not quite as acidic as cola, for example, which is what I usually recommend if you're in this kind of situation. And here's some data about the frequency of the drug and whether or not you take it with food. So you can see 400 milligrams twice a day alone is substantially lower AUC than if you take it with boost. 200 milligrams 4 times a day alone is dramatically better absorbed than the 400 milligrams twice a day. Okay, this is 7 days worth of data. And 200 milligrams 4 times a day plus boost actually wasn't really all that much better. So if your patient's borderline on their ability to eat, you're much better off if you can get them to be compliant with the 200 milligrams 4 times a day. Obviously, those two things go in two different directions, compliance and absorption here. Now, how important is this? Well, for prophylaxis, it may not be all that important, and that's what the manufacturer will state. You know, in their clinical trial in the AML MDS patients with prolonged neutropenia, a tenth of their patients had an average concentration of less than 200 nanograms per ml, and none of these patients developed invasive fungal infection. So they'll state that this doesn't really matter. But they did see that proton pump inhibitors were more likely, patients on proton pump inhibitors were more likely to have a low concentration, diarrhea. Interestingly, non-white race and elevated GGT. So maybe some of these things were data dredging, but nonetheless, it's consistent with the other data that we saw. H2 blockers don't seem to have a dramatic impact here. So I don't worry about it too much when I'm using it for prophylaxis. But when we're talking about treatment of invasive fungal infections, I think it's more clinically significant, particularly in borderline patients, and we'll talk about that later with the aspergillosis data. In terms of distribution for these drugs, both drugs have excellent distribution. Also, most drugs have very significant CNS penetration. Voriconazole, we've got a couple patients who had CSF levels of 36 to 68% of what they had in their bloodstream. Posaconazole, I don't have that kind of data, but what I do have is a case series of patients with CNS infections with about a 48%, 50% response rate in patients with CNS invasive fungal infections. So that certainly suggests that the drug's getting into the CNS. So that's very useful for us. I'm going to talk about renal insufficiency a little bit. I know I've talked to a fair number of people in this room about this issue. There's a warning in the package insert that says that consider the risk versus benefit of using intravenous voriconazole if the creatinine clearance is less than 50. Now, voriconazole clearance itself is not cleared renally, so your voriconazole concentrations are the same. However, you have the solubilizing agent. Okay, this is a polysaccharide. It is the poor man's liposome. Okay, so what you have is in here in the center where you have your voriconazole, it's very lipid loving and hydrophobic, and the exterior is more hydrophilic. That's how you're able to get this drug into solution. Otherwise, it just crystallizes out. But what happens? This will accumulate with renal failure, and the only data that I've seen is that if you give this to rats and you damage their kidneys, you will get these high levels of the cyclodextrin, and their proximal renal tubules, they'll wind up with these vesicles that are loaded with cyclodextrin. Nobody knows what that means. Nobody knows if that's actually nephrotoxic. So it's a theoretical concern. So if you have a patient for whom voriconazole is a drug of choice and they can't take it by mouth and they have renal insufficiency, I would press on with the IV in that scenario. Posaconazole, essentially no impact here on with renal insufficiency on posaconazole. The one thing that was noted in the package insert is that patients with severe renal insufficiency had a much higher coefficient of variation. So they had some patients with very low levels, some patients with very high levels. Speculating, perhaps those are just generally sicker patients. But moving from the kidney over to the liver, voriconazole in the liver is a fairly complicated subject matter. Voriconazole is metabolized primarily by 2C19, but it's also partially metabolized by 2C9 and 3A4. But we can really focus here because this is the most significant. And it's important to note that there's substantial genetic polymorphism of CYP2C19. So 15 to 20% of Asians, 3 to 5% of Caucasians and African Americans exhibit reduced clearance of voriconazole. So if one is homozygous for the trait of reduced 2C19 production, you tend to have fourfold higher voriconazole concentrations than a patient who does not have this trait. And if you're heterozygous for the trait, you tend to have twofold higher voriconazole concentrations. Considering that there are concentration-dependent toxicities that are relevant with this drug, this becomes very important. We talked about posaconazole has saturable absorption. Voriconazole, on the other side, has saturable metabolism. So therefore, you wind up with a nonlinear pharmacokinetics. So you get more bang for your buck than just proportionate for increasing the dose. And we'll get a little bit more into that with dosing. Also, it's important to note that voriconazole inhibits 2C19, 2C9, and 3A4. Now, voriconazole has been used in patients for serious invasive fungal infections for patients with profound elevations in AST/ALT. These patients clearly have to be very closely monitored, but you don't adjust your dose. Okay. And you don't use it lightly. I wouldn't give somebody with 5 times the upper limits of normal voriconazole for prophylaxis, for example. But if they had a rip-roaring invasive aspergillosis, I would. Now, this is a somewhat troublesome area to me, elevated Child-Pugh scores. So what they did is they took cirrhotic patients, and they gave them voriconazole, and they looked at their pharmacokinetics. And they found that patients with chronic liver failure who are Child-Pugh score A or B, so mild or moderate cirrhosis, that they recommend a 50% reduction in the maintenance dose of the drug. Child-Pugh score C, severe cirrhosis, has not been studied. Now, this scoring system has not been validated for BMT patients, solid organ transplant patients, patients who might have, say, a toxic acute hepatic dysfunction. So I think there's a role for therapeutic drug monitor and for being a little cautious about particularly patients with mild hepatic dysfunction by Child-Pugh score. Other thing to be aware of is they have things like albumin in there. Patients may have other reasons other than poor hepatic synthesis of albumin to have low albumin. They may be malnourished, for example. So this is actually the table here. I'm not going to go through it, of the Child-Pugh score system. So it's very easy for patients with some mild hepatic dysfunction to wind up at least as an A. So I always get a little cautious about dropping my dose too aggressively, since most of these patients aren't really chronic liver failure patients. Posaconazole, on the other hand, is primarily metabolized by UDP glucuronidation. So there are no major oxidative or cytochrome P450 mediated metabolites. And the package insert is kind of a bland statement about the PK data is not sufficient to determine if dose reduction is required. The bottom line, I think the next slide answers that question to my satisfaction. You know, normal, mild, moderate, severe hepatic dysfunction. Okay. Bottom line is I would not adjust my dose of posaconazole based on hepatic dysfunction. I would monitor those patients extremely closely, as if you aggravate their liver dysfunction with an azole, then they may not be able to stay on that azole very long. The other thing I wanted to note is that Posaconazole inhibits CYP3A4 only, so it doesn't affect 2C19 or 2C9. So again, this is kind of going back to where I was talking about. Fluconazole inhibits multiple isozymes like voriconazole, although voriconazole is a little more potent than fluconazole at it. Posaconazole and itraconazole both are specific to 3A4. Okay, in terms of the effect of drugs on the azoles, voricanazole's concentrations are reduced by enzyme inhibitors. So phenytoin is an interesting drug interaction here. If you got a patient on phenytoin and you want to start Vori, be aware that you have to double your voriconazole dose, at least if you were planning on giving 200 BID. And then count on the fact that the voriconazole is going to inhibit the metabolism of the phenytoin, so your phenytoin will probably need to be reduced. Yeah, because your phenytoin levels will go up. Rifabutin and rifampin, there is a profound effect, and it is kind of challenging how best to deal with it. I haven't really had much experience with this, but they say that it's contraindicated in the package insert. You could probably work your way around it with caution and a good clinical pharmacy consult and lots of drug levels. But rifabutin decreases the Cmax by 67% and the AUC by 79%. If you double the dose, you overshoot, so you probably wouldn't want to go quite that far, maybe 1.5 times the dose. Rifabutin, however, shoots up to 3 to 4 times the normal concentration, so you'd have to back down on your rifabutin dose. Rifampin and voriconazole just do not mix. I mean, look, there's 93% reduction in Cmax, 96% reduction in voriconazole area under the curve, and doubling the dose just doesn't get it done. Okay, in terms of carbamazepine phenobarbital, there's no good data. You would expect it to induce voriconazole metabolism, so it probably wouldn't be the best scenario. Try to avoid it. Certainly not use it as a single agent. Do therapeutic drug monitoring. Dose aggressively. Realize that you may not get there anyway. Voriconazole could potentially be increased if you have an enzyme inhibitor to 2C19. And interestingly enough, some of the proton pump inhibitors can potentially inhibit it. Package insert will say this is not a clinically significant difference. Omeprazole in this one study, 15% increase in Cmax, steady state, area in the curve by 40%. So they recommend no change in Vori dosing. Consider capping omeprazole dosing at 20 milligrams a day, although there's a lot of great therapeutic window with this drug, so I don't tend to worry about it too much. Massive doses have been given for people with Zollinger-Ellison syndrome. However, you'll see that maybe in some specific patients, this actually is a clinically relevant drug interaction. We'll come to that. Posaconazole, no one's been able to explain to me why cimetidine can decrease the concentrations of posaconazole, but no one uses cimetidine anymore, so probably not a big deal. Also, you want to tend to avoid things like rifabutin, phenytoin as well. Very similar there. Now, here's kind of a laundry list of some of the drugs that you have to think about with these agents, where if you give them in combination, you may see increased concentrations of these agents and potentially increased toxicity. And so sirolimus is a massive one we'll talk about shortly. These are QT prolonging drugs, plus voriconazole and posaconazole can prolong QT, so that's a double whammy. Ergotism with ergot alkaloids, you have to reduce your doses with your cyclosporin, tacrolimus. Warfarin's probably a bigger issue with voriconazole. It's a major drug interaction. 3A4 is not nearly as important in warfarin metabolism, so posaconazole is probably a better choice if you have to have somebody on warfarin. Monitor patients on methadone and fentanyl for increased sedation. Statins, potentially increased risk of rhabdo or myopathy, so just be aware of that. We generally reduce our 3A4 cleared statins by 50% when we start one of these drugs. It's empiric, but it seems reasonable. Drugs like pravastatin actually have very little 3A4 clearance and can be used at full dose. Some of the calcium channel blockers need to be monitored closely, sulfonylureas. Chemotherapy can be a major issue if it's 3A4 cleared. We mentioned phenobarbital before, proton pump inhibitors. Also, some of the HIV protease inhibitors and non-nucleoside reverse transcriptase inhibitors. So
always, with HIV patients, always do a very thorough search whenever you think about adding one of these drugs to a patient's regimen. So these are the adjustments that we make for tacrolimus and cyclosporin. These are manageable as long as you have somebody paying attention and doing the levels. Sirolimus you have to really keep a close eye on. You may have to reduce your sirolimus dose to 10%, maybe up to 33% of the starting dose. So that's a massive, and if you just start the drug and don't realize it, patients start to develop things like TTP, and you have very unhappy transplanters. This is some data that we had from Moffitt with busulfan, which is a 3A4 metabolized drug, and what we saw was that there was indeed some effect on its metabolism, particularly with the posaconazole, but in fact it was manageable with therapeutic drug monitoring that you do for busulfan. Azole interactions with chemotherapy. Vinca alkaloids we want to avoid because they're 3A4 metabolized. They have potential to cause peripheral neuropathy if you have excessive accumulation. The toposidin and taxanes are also metabolized by 3A4. Potential to decrease bioactivation and efficacy of drugs like ifosfamide, which is 3A4 activated. I'm going to skip over the high-dose cyclophosphamide pharmacokinetics aspect of this talk. The one thing that I will say is kind of on this slide, fluconazole plus high-dose cyclophosphamide, you can actually see a shift in the metabolites towards less toxic, less active, which might be why that initial data with prophylaxis of fluconazole actually showed decreased toxicity, because you may have had less cytoxin toxicity in that group. More toxicity has been seen with itraconazole concurrently, so you're not going to want to give that concurrently with high dose of cyclophosphamide. We don't really know what impact voriconazole would have. Yeah, it suggests that it would have more of a fluconazole kind of picture than an itraconazole kind of picture. Posaconazole, I would expect a really bad idea to mix itraconazole with high dose cyclophosphamide. I would expect it to be comparable to what you see with itraconazole. I can't prove that. Okay, in terms of clearance, voriconazole, half-life is about 6 hours, but it's concentration-dependent, non-linear kinetics. So the higher the concentration, the higher the half-life, just like phenytoin. Posaconazole, about a 35-hour half-life. So what matters, clinical impact, posaconazole concentrations less affected by a single missed dose. That's a good thing. However, longer washout period with posaconazole to avoid drug interactions after discontinuing the antifungal. So, you might get by with two-day, giving your chemotherapy 2 days after you stop the voriconazole. You'd have to wait like 7 days at least for posaconazole, and that's usually not clinically manageable. That's why we like to use voriconazole with vincristine. Hold it the Vori 2 days before, 2 days after. This is just some data supporting the fact that loading doses, either these oral or IV loading doses, get you to a steady state concentration much faster. Otherwise, you have to wait till day 6. This is what I mentioned before. 2 to 3. If you increase your dose from 200 milligrams to 300 milligrams BID, you increase your area under the curve about 2.3 to 2.5 fold. So it's important to realize that we don't want to just double, triple our voriconazole doses willy-nilly. Voriconazole therapeutic drug monitoring, there really does seem to be a role for this in clinical practice. Okay, this group measured 181 voriconazole trough levels in 52 patients with invasive fungal infections. They found that the most desirable trough concentration levels were 1 to 5.5 milligrams per liter. They had, again, fairly small number of patients, but 54% treatment success in 13 patients with a trough level of less than or equal to 1. Now, of the 6 that failed, they bumped up their voriconazole dose by 50%. And in this small group, they actually salvaged all 6 of these patients. 5 with Aspergillosis, 1 with disseminated Candidiasis, without making any other changes. Now, caveat is that's a small number of patients, and they had these levels available to them immediately, whereas we have to wait a week to get the results. Nonetheless, 88% response rate in the 39 patients who had therapeutic trough levels. Also, Voriconazole TDM is relevant in regards to toxicity. So encephalopathy. In this group, they had no cases of encephalopathy when the trough was less than or equal to 5.5. 5 cases, 31% of those patients, where the trough was greater than 5.5. And it occurred a median of 9 days after start. And when they had troughs just over 5.5, they had about a 15% incidence. When troughs got up to 8, they had like a 90% incidence. So something to bear in mind as we're escalating voriconazole doses, something to be alert for. Note, the data is not real clear as to whether hepatic dysfunction increases with increasing levels. They weren't able to verify that here. Interestingly, among their patients with elevated levels, they actually saw a higher frequency of patients being on omeprazole. So 17 of their patients with trough concentrations of less than or equal to 5.5 were on omeprazole. 44% of those with elevated concentrations were on omeprazole. So that drug interaction I mentioned as not being clinically significant, maybe in some patients. Posaconazole TDM, I haven't found this to be nearly as useful as voriconazole at this stage of the game. As I mentioned, for prophylaxis, it doesn't seem to be particularly valuable. This is a Aspergillosis salvage therapy data, and they broke down by quatriles. The patients who had the highest posaconazole levels had the highest response rate at 75%, whereas those in the middle had about a 53% response rate, and those with the very lowest concentrations, a 24% response rate. So this may be clinically meaningful, but we are somewhat limited in our ability to manipulate these concentrations. Yes, get your patients to take it perhaps more frequently, get them to take it with food, get them to take it perhaps with some cola and so forth. But since we don't have an IV formulation, since the absorption is saturable, you can't just keep increasing the dose until you get where you want to get. It's kind of exactly the opposite of voriconazole. So these are kind of like your standard voriconazole dosing guidelines. Per the package insert, I generally give doses greater than 400 as IV. Obtain a voriconazole trough in 5 to 7 days for patients with invasive fungal infections, not for prophylaxis, and adjust your dosing to achieve a trough in the goal range. Similar with persistent neutropenic fever, some people use 3 mg per kg instead of 4. Prophylaxis usually a little bit lower, 200 milligrams POBID in most cases. We talked about the renal insufficiency, hepatic insufficiency adjustments, and consider TDM patients with breakthrough fungal infections on voriconazole and encephalopathy on voriconazole while you're holding and or reducing your dose. And consider as well in patients with borderline hepatic dysfunction. Posaconazole, there's your prophy dose, the 200 PO TID with meals or with a nutritional supplement. Consider changing the patient to voriconazole if severely poor PO intake. And 200 QID for initial treatment, usually 400 BID, but consider bouncing it back up to that if your patient's not eating. And no dose adjustments for renal or hepatic insufficiency. So that's some of the cost data for Moffitt. Obviously, these drugs are significantly expensive, and we need to be aware not to use them lightly. So hopefully I haven't drowned you guys in data on these agents. And if you're not too buried, I will take any questions that you might have at this time. Yes?
Comparison between Vori and Posaconazole for brief abusing, are they the same consideration, the precaution that we have to take for Posaconazole as well as Voriconazole?
Actually, and it's an excellent question, and I think I'd actually have to go back and see if there's. The last time I looked, the Posaconazole, it wasn't based on PK data. It was based on it was a caution based on an expectation that that you would have a significant interaction. There's some data with there's some specifically some data with phenytoin, and it looks like it's more problematic than with voriconazole. The big problem that you have here, I think, is that, again, because you have saturable absorption with posaconazole and no IV formulation, if you induce the metabolism of the drug and the levels fall, you can't just double your dose and overcome that. So posaconazole might be a more difficult agent to use in that setting, whereas voriconazole, you can at least, not with rifampin as I demonstrated, it's just too potent of an effect, but with rifabutin, you can increase your dose of voriconazole, monitor your levels of voriconazole just based on levels. That's one thing I do like about voriconazole is I have an IV dosage form, but I usually don't need one because it's so well absorbed. Posaconazole has an absorption problem, but we don't have an IV dosage form. So that's kind of a sticking point with the use of posaconazole. They're having a hard time making a commercially practical IV formulation of that drug. Yes, Richard.
Yeah, speaking, Rod, of Posaconazole, there was that study in antimicrobial agents in chemotherapy last October by Abraham that showed, I guess they studied either monotherapy with Posaconazole or combination therapy with Ambisome in a rat model for the treatment of invasive zygomycosis.
Mm-hmm.
Either rats with diabetic ketoacidosis or neutropenia, and they found that the combination of Posaconazole and Ambisome, those rats didn't really do any better, and also the Posaconazole monotherapy rats, the use of versus placebo, the rats receiving Posaconazole, it didn't improve their survival, and actually it didn't reduce organism burden versus placebo. So my question is, are we using less Posaconazole for zygomycosis at Moffitt? In your observation, are we moving more towards Ambisome? I mean, that's the impression I got from IDSA ICAC this year, that there was kind of disfavor for Posaconazole and zygomycosis therapy, versus prophylaxis.
Okay. Well, I think that it's clearly, when we're talking about rodent data, it demonstrates just how much of an unanswered question it is. But often we're stuck with it given the relative infrequency of these diseases and the severity of the disease. Now, if just kind of flipping through to the Posaconazole salvage data. Now again, it's certainly not a randomized trial. It was 107 patients who received Posaconazole for Aspergillosis who had failed a frontline therapy, generally an amphotericin B product, compared with 86 matched historical control subjects who were not able to get the study drug. Was before this compassionate use study was available, and there did seem to be perhaps a little bit of an advantage. Oh, that's Aspergillus. Sorry. Yeah, actually, the data was more impressive with zygomycoses in this group than with Aspergillus in a similar kind of study. So I'm sorry, this was a very small number of patients, 24 patients, compassionate use trial, and they had about an 80% response rate, and 19 out of 24 patients survived. But they had no comparator group, unlike Aspergillus, because they were able to get more patients and actually have a historical control group. So, I think this tiny little data is what a lot of people said. Well, we've got an active drug. Let's throw it in there. My experience has been patients who have a serious zygomycosis. These patients are so medically ill in general that they're not the best candidates to absorb their Posaconazole. So they may that's probably not valid in terms of the mouse study. That may be even further data suggesting that the drug in and of itself, certainly as monotherapy, might be disappointing. I would be interested to see. Do you know if they used an intravenous formulation of Posaconazole? I'd be interested to see if they're ever able to come up with an IV formulation of Posaconazole. Would that have a positive impact in treating us, like a zygomycosis, for example? Because I know my patients, they're talking about giving it down a tube, and with the PK data, the absorption issues I've talked about, it's just not a great down the tube kind of drug. So essentially, that's what you're doing with the rats, probably as well. But nonetheless, they probably were able to give it enough to get significant Posaconazole concentrations. I didn't read that particular report. So I think clearly we would use like a lipid formulation of amphotericin B. Generally, though, we're still throwing in the Posaconazole in the idea that it's probably not doing us any harm, and it's still holding out the hope that there's some benefit in a high-risk patient.
Maybe the issue here, as you said, was there's it's a lot easier to do animal studies. Maybe there's just not that many study subjects to look at Posaconazole therapy response in human patients. Maybe that study is difficult to do, except in very small numbers.
Oh yeah, and this is
I was going to say, personally, right before Posaconazole was approved by the FDA, we had a patient who we managed to get Posaconazole as compassionate use. He was a diabetic patient, and who had orbital compromise, and actually did very well with Posaconazole monotherapy, for the most part monotherapy, and survived. So it's interesting, but I guess sometimes these animal studies throw the accepted practice into question.
well, and the one thing that I think that points out a little bit of a difference between the Posaconazole and Aspergillus salvage therapy data here is that probably the patients who were getting Posaconazole for salvage therapy for Aspergillus had a more refractory infection. Whereas these patients really may not have received antifungal agents with optimal anti-zygomycosis activity. So I mean, yes, they're not getting better, but you're also not really treating them because we have so few choices. So
I wonder if it's part of this trial because it's around this time. So I don't know.
yeah. So there's still that old ongoing question about whether amphotericin B binds at ergosterol. You're inhibiting ergosterol synthesis. So is there some kind of antagonism? That seems to be very pathogen specific, very strain specific. As to there doesn't seem, the data that I've seen doesn't suggest that the azoles and amphotericin B concurrently have a antagonistic effect in the majority of cases. There may be some cases. Many you're lucky to get additive, of course, and a lot of indifference. But
Maybe this is a good question to ask Dr. Rod, who's going to be here from MD Anderson next week to talk to us about infections. So that might be a good
absolutely.
ask him.
Okay. Any other questions? Okay. Well, thank you guys for your attention.